Good afternoon, everyone, and a very warm welcome from all of us conducting this instruction course here in this prestigious AIOC meeting in Mumbai, DreamCon. On behalf of all the members here in this instruction course, I would like to thank everybody present here. It's a golden and prestigious moment for all of us. I thank AIOC, the office bearers, especially Dr. Partha, who gave us this opportunity to give our views on why and how we get an unhappy patient after doing a good surgery. So today the agenda is all of us face some unhappy patient in our OPD after surgery. Our intentions were good, our efforts were good, but then what happened? What went wrong? So here are some take-home messages that you will get to know that what goes wrong after an uneventful surgery or after a good surgery done and we land up in an unhappy patient post-operatively. With me is myself, Dr. MOHIT KHATTRI from Kanpur, and I am having Dr. Anaga today with us from Mumbai, Dr. Manish Mahindra from Kanpur, Dr. Shalini Mohan from Kanpur, and we'll be shortly having Dr. Suhas Haldipurkar from Mumbai and Dr. A.K. Grover, our past AIOC president from New Delhi. First session would be taken by myself, and I'll be taking those points what we miss clinically in our OPD when we plan surgery. Please load my presentation. And what today I'll be sharing is what I missed it. My presentation would be a collection of small fables that myself faced in my career. This is a short story of a precious multifocal I did. It was a clear and simple case. Patient came for cataract surgery in left eye. She had a good grade 2 cataract in left eye with a normal fundus. IOL power was done by IOL master. 24.5 diopter was the power. In the right eye, the patient was pseudophakic, done somewhere else. Good 6.6 N6 vision and a multifocal in situ. Obviously, I planned a multifocal. And then a good multifocal was done. Nice looking surgery, good, well centered IOL, and I was happy. Then, in post-op, patient came out to be 618, N10, not improving with glass. I was quiet, nothing wrong. My confidence was shattered. Something has happened. Optometrist came running. Literally, I pulled my hair. When I thought back, was I dealing with some amblyopia? I had no details of the other eye. The other eye patient was happy. I never gave any attention. I did the other eye. IOL power was not bad, 24.5, but still I was dealing that. So what carry home message we got? Whatever is the other eye, please try to probe into the papers of that, get record of what lens was implanted, what power was used, was the patient wearing glasses, was there any disparity in vision in both the eyes, at least ask that thing, so that you can raise a red flag if you suspect amblyopia in the patient. I am busy, especially in winters. Another case scenario, the patient was worked up by optometrist. I saw the patient under dilated state. All readings were nice and good. Finally, a premium IOL was planned and monofocal, and in fact a good surgery done. Nice rexis, bit large, good overlap, and patient had a quiet eye. Post-operatively again 618, not improving again, quiet eye. My mouth was wide open as I gazed into Amma's eye and saw that it is divergent. I never ever thought that I have to put a torchlight before cataract surgery. So I was busy. My eyes were stuck into the eyepiece of slit lamp. I am busy surgeon. I saw the patient under slit lamp, and believe me, her husband never knew that she is having a deviated eye. Must be 30 years after marriage. This is the state. Then a very common complaint. You put a diamond in the eye, but the patient is not happy. Gada raha hai, chubh raha hai, dard ho raha hai. And the eye which you operate, that only aches. That only is red, that only itches. So, non-resolving grittiness and discomfort after cataract surgery is very common. We see the grade of cataract, we see whether or not any comorbidity is there, but then we give copious amount of drops. Patient is having keratitis, make 1 hourly prednisolone. Okay, done. But the lady will come every third day and say that it is discomforting. Might be 6/6, but patient is unhappy again. So if you have a meibomian gland dysfunction, if you have severe dry eye, please treat a few days before you put a knife into the eye. That is the message I would like to give here. Another interesting case of a mature cataract. This is the figure, a Morgagnian cataract, PR accurate, other eye is having an immature cataract, IOP fine, fundus not visible obviously. Again seen by me in dilated state. See how busy I am. I saw there is no pseudoexfoliation, there is no subluxation. B scan was done nicely. Then I thought, should I do SICS? Am I good at phaco? I was heroic. I had a new machine. I will do phaco. I did it. I boasted off in OT. See how good surgeon I am. I chopped it. Nicely done. While doing, I saw this. Oh my God. He had a PI. Nobody told me. Okay. Then this had to happen. Finger counting 2 meters post-operatively. Glaucomatous optic atrophy. Never expected this. So again a lesson learned. See under undilated state also. Lift the eyelid up. Today I was in a glaucoma session. Dr. Shalini was teaching this. Lift the eyelid up before you take up for surgery. This could have been seen, but I am a busy surgeon. I can't. And I did not. So, a small Pandora box. This was a very naughty child, sustained trauma, came up with this kind of state. A small brown thing you can see over the cataract. It was a wooden stick injury. I thought might be some pigment, might be a foreign body, not visible. Child was just running here and there. I could see only under torchlight. Then, very uncooperative child. I could just throw some light from indirect and a good glow was coming. Fine. Finally decided to take the child under GA and took it up for surgery. While doing surgery, I saw this. What is this? Is it an entry wound? Okay, let me handle. I took the lens aspiration process done. Then I saw this, a small PC tear. I don't know whether I did that time. I don't know whether it was pre-existing, but then it was there. Then again my confidence was on the 7th heaven. I am very confident. I will put the IOL in the bag. I did it. Nice surgery done. Then patient 660, attendants unhappy. Earlier a 5 feet attendant was there, then 6.5 feet people started coming in my OPD. I was scared. See this fundus? Foreign body just near macula. Now IOL is there on the roof. How to take it out? What to do? If I take this out, where will I laser? Will I laser on the macula itself? Bad state. Maybe an X-ray would have been useful. Lesson learned. Be more patient before you take up these cases. Should I have a microscopic eye in my OPD also? I tell you a small story of 2012. A retired scientist from IIPR Institute in Kanpur visited me for surgery. A bliss, scientist, very good gentleman, 636, good grade cataract, even I smiled and he smiled. Good surgery done by God's grace. He was 612, not improving with glass, poor reading vision, quiet eye. Those were new days for OCT. I called him for OCT and I said, I welcome Dr. Suhas, please sir, join us here. So, there it was quiet eye again, but the scientist had his own plans. Something is wrong. What was wrong? I just missed a pseudomacular hole over there. This could have easily been missed by any clinical examination. Excuse me. Dr. Grover was calling. Can anybody call? And tell Dr. Shalini, please pursue. So, I missed a pseudomacular hole behind a grade 3 cataract. Anybody could have missed it. But then, I tell you the truth, he sued me. He stopped coming and I received a letter from an advocate. People are literally ruthless and anybody of us can face it. Now the question is, should an OCT macular scan be done for all cataract patients preoperatively so that you have something? I don't know, but The lesson learned is very careful written examination is must, and if you still have any doubt, please do an OCT so that you have something on paper before you have a legal liability on your head. To conclude, it's smart and good to learn from your mistakes, but I tell you, it is better to learn from others' mistakes. And today I am putting forward my mistakes. So please do learn from my mistakes, and that might help to smoothen your career. Thank you.